This conference will now be recorded.
All
There
right,
you go.
we're live and in color. All right. Well, as most of you gentlemen know, that we devote the beginning of the program to new people, people that are here for the first time, to try to get acquainted with them, tell them what we do, get some history of where they are in this journey. Relatively new to the journey, I take it. But without further ado, Max, you were on, and did you go away?
I'm still here. I just never been in the group before, and the idea of putting this straight out on the internet, I just decided to,
Not a problem.
turn off the video.
Okay, not a
Yeah.
problem. Okay, well, what we're going to do, Max, we're going to ask you, I'm going to ask you to start with just a series of questions. We basically came up with a little, almost an interview type process so we can find out where you are in the journey, and help you, in order to give you the most information and help you. So if you get uncomfortable, if you really don't want to do this, that's not a problem either, but I hope that you'll bear with us. This is just we found this to be a good way to basically um, get information about where you are, where you're getting treated, and specifics about uh, the process of the disease at this point. So, Max Caruso, where are you located, Max?
I live in Sonoma County, Sebastopol, California.
Okay, I got a lot of people, as well, a few people out there in California for sure. And how did you hear about ANCAN? How did you hear about this group?
I was on I'm on a Facebook group for non-surgical prostate cancer, and somebody posted, "Hey, join this meeting tonight." So I clicked on the link and learned a little bit and figured out how to join you.
Okay, excellent. Glad to have you. Glad to what you call it. Glad that you're here. And what we would like is to make sure that we get your email, so we can make sure you can put it in the chat and just send it out to you, the organizer. And do you know what the chat room is?
I can probably figure it out.
It's the two boxes that are kind of interlooped on the top right of the screen,
Okay.
and you can send a message to whoever you want or to the group. But if you would make sure that we get your email, to make sure that we get that you get the weekly reminders. Okay.
All right.
How old are you, and are you a veteran?
Yeah, I'm 56 and I am a veteran.
Okay. We also have a veterans group that I can tell you about too later on. Okay, when were you first diagnosed, and how did that come about?
Yeah, I guess when I was turning 50 about 6 years ago, I did a panel including PSA, and my PSA was 6 point something, a little below 7. So that was end of 2018. So they did an MRI and found some suspicious things. So in February of 2019, I had my first biopsy. I could go on, but I think that's what I'll try to just stick with what you ask.
Okay, well, we'll get back to that because I'm sure other people have some questions too. Where are you being treated? Where do you go?
It's mostly the VA, San Francisco VA, so they use UCSF doctors. So that system there.
Well, that's a center of excellence, so you're getting excellent care with the UCSF people. You said your PSA history was back like 6'8" in 2018. What is it now?
It's been mostly 16 something this year. I think one test about a year ago was a little bit above 17, but it's last one I do it quarterly was 16.8 or something like that.
Okay, all right. And the last MRI you had it can't be 2018, I hope.
No, I did a couple of them before. The last MRI was right before my biopsy in July, my second confirmatory biopsy, which was July of 2024. So probably in May of 2024 or June of 2024, I had my last biopsy, or I'm sorry, MRI.
So what is your
Okay.
biopsy results?
Both of them, 2019 and 2024, were Gleason 3+4. So I guess they call it grade group 2 now, like an unfavorable is what Dr. Cooperberg called it. So
Right.
yeah, that's it. Gleason 7, 3 plus
So
4.
how many cores? Gleason 7s.
I'd have to pull that up. I don't have it off the top of my head, but I know technically just under half of that first biopsy, they found, either 3+3 or 3+4. I actually just by chance talked to Dr. Cooperberg again yesterday. It kind of motivated me to learn more. But it is on both sides. So I have lobes. Each side of the lobe has some 3+4, but the 4 wasn't like above 50% or in any of the samples as far as I remember. So they took like 19 samples and maybe 8 of them had cancer the first time.
Okay. Did he consider you, what do I want to say? High volume?
I don't think so. I mean, in his report, he said the majority, it was kind of just a difference of 1, so almost half the samples had it. But when you say
Okay.
high volume, do you mean like high volume of cancer within the biopsy samples or?
Yeah, usually I think they usually consider high volume anything over 50% of the cores. So in your case, you had 19 cores. If half of them show as having cancer. You said you had did you say you had 2 that have 3+4s?
Yeah, I got the second biopsy last summer. That one was at UCSF. The first one was at the VA, and Dr. Shinohara did a transperineal the second time. And so I think there probably was more than 50%. I'm pretty sure of this one because they were so targeted. They got, more than half of the samples they took had
That's
some
true.
kind
The
of
two,
cancer.
the two names that you mentioned, Shinohara and Cooperberg, are definitely names that we know and are well respected. Now, I'm trying to see if maybe you're not in the right. We also have a group for low and intermediate, and it might be that might be a better fit for where you are in the journey right now. But as you said, a little curious on the volume of the grade group 4. What has been their recommendation? Have they been recommending active surveillance to you, Max?
No, Dr. Cooperberg wanted to cut it out in 2019, and I did go see Dr. Wong, a radiologist, maybe on call. I don't know what they're called. A guy, radiation guy at UCSF as well, just to explore the options. And again, when I hadn't talked to Cooperberg since 2019, but I talked to him for 30 minutes yesterday on the phone, and he again was, strongly encouraging me to not wait to get it treated.
What's he say about your PSA? And you sound like, 16 and 17, that's pretty high.
Yeah, the doubling rate, because I did when I was in the Coast Guard earlier, maybe 10 years before, I did do a PSA test and it was low. So I think my doubling rate is like 4.2 years. And, but yes, because I have PSA of just around 17, we'll call it. My highest ever was just over 17. That's one of the reasons he wants to, encourage me to seek treatment in the next year or so.
And Max, have you had your biopsies, a second opinion on your biopsies?
Nope, I didn't. I did get Decipher testing on both of them though, but I did not have, send them off to Hopkins or do any second opinions. Nope.
And what did the Decipher say?
The first one was 0.41 and the second one was 0.47.
So I don't know the actual Decipher. I don't know if we got somebody on here. Was that a high risk or a low risk, or what is it?
Yeah, the 0.41 was low, and then I happened to have the Decipher that I just pulled down yesterday after talking to the doctor. And the next one was 0.47, and it shows intermediate risk. So I'm at the low end of intermediate.
Yeah.
Yeah.
So why haven't you not gotten the your biopsies, at least your latest biopsy, a second opinion?
Well, because it didn't show dramatic change over the 5.5 years, just like the MRIs didn't show dramatic change. And, like someone already mentioned, Shinohara and UCSF are a center of excellence. So, maybe, and it wasn't just like I was right on the edge of anything. It just seemed to be pretty much the same old, stuff. And I did get a PSMA PET scan. I don't know if you guys are going to ask me that next, but the short answer is I just didn't think it was worth getting a second opinion just because the second biopsy, I guess, was kind of my second opinion,
Yeah.
the
Oh,
confirmatory.
well,
What did
you know,
PSMA PET show?
It showed no, it didn't find any metastasis.
Good.
Yeah.
Excellent. I know, I think Phil in Toronto has a question for you, Max.
Well, just, I mean, Cooperberg is definitely a proactive surveillance guy for sure. So, when he suggests treatment, I mean, it's obviously something like, have you considered treatment?
Yeah, I think it's in my future. I just, I was 50 years old when he was talking to me 6 years ago, and I just had the feeling because the Decipher score was in the low risk,
Yeah.
and I'm trying to take good care of myself. I didn't want to have the side effects of either, radical prostatectomy or radiation when I was 50 years old. Now I'm 56. So it's, I might, I'm more open to it. And I totally hear what you're saying. Cooperberg's an expert, and he told me that yesterday that he's very pro active surveillance, and he thinks
Yeah.
I probably shouldn't be on it for, for forever.
Yeah.
Yeah, I don't want the short answer is I haven't gotten treatment yet because the risks of side effects are not appealing, and I don't feel like it's, I'm on the verge of metastasis, even though I have no clue it could have happened. The way Cooperberg said it, just to real quick tell you what he said that mostly scared me yesterday. He's like, sometimes he takes out people's prostates and then years later they find, some metastasis in a bone, and he said that, that means it escaped, and was slowly growing in the bone before they removed the prostate. That's what he said. So that's
I
kind
mean,
of scary.
Yeah, I kind of think that if you join the ANCAN, low to, low to intermediate group, it might give you the opportunity to speak to guys who have been in the same position as yourself, and discuss risk and stuff like that. I guess that's the scariest part, because you hear about all the bad things that could happen to you because of treatment. But I mean, there are plenty of guys who have had treatment who don't who don't incur the bad things, and come out of it pretty well. So obviously you begin to think about all the ED and incontinence and all that. I mean, there are plenty of guys who've gone through treatment and are totally okay.
Mm-hmm.
Yeah, that's true. There are some men that fare well, very well after treatment. And then in the low and intermediate group, that would be the place where you could speak about treatment. We really don't talk about treatment in this group.
Yeah.
Because we're trying, everybody's on active surveillance, trying to avoid treatment for as long as possible. And in the low and intermediate, those are people that have made the decision, or they're in the decision-making process, and they might have a lot of insight that you might appreciate, because again, it's a peer group. It's a guy talking to a guy, or perhaps his wife. We welcome women, partners, whatever, but you get it straight from the horse's mouth, so to speak, people that are in the same boat as you are. I know Derek had his hand up. Go ahead, Derek.
Hey, Max, welcome. Thank you for taking the time out to join the group and sharing your story. Much appreciated. Question: is there any family history in your?
Yeah, one of my two grandfathers did die of prostate cancer, even though I think he probably had lung cancer as the same. And my dad had high PS. He didn't have a biopsy. He's still alive. He has BPH, so he has not been diagnosed with prostate cancer, and I think his PSA is a lot lower than mine. So yeah, one grandfather died of it, and 23andMe, I did that years ago genetically, and I was at increased risk for prostate cancer.
You were.
Yeah.
Have you done any recent genetic testing on the current samples?
Well, yeah, I did the Decipher 10. That might be genomic, not genetic, but I did actually consult with, I think, my other healthcare is through like Providence, and there was a Southern California group that did genetics, and they took my blood and made sure I didn't have a certain gene that's, associated with the, the more aggressive cancer. And I did not have that gene. So I did at one point in between the two biopsies, I consulted with a geneticist or something like that.
Thank you.
Okay. I know Michael
Gary,
had his
Michael-
hand up in Tennessee.
Yeah, and I have a feeling I know where he's going to go. Go, Mike.
Well, Max, yeah, I was just going to say I'm kind of in the same boat that you started in. I'm approaching 50, and I definitely a huge proponent of a second opinion on the pathology. But also, I guess the main thing I wanted to say is I kind of ping pong ball back and forth between this group and the intermediate group for quite some time, actually, and learned a lot from each. So I just wanted to point out that you may want to check out both.
Okay. Yeah, and I am curious. I probably should thank you, Michael, for pointing that out. I am curious if this is not the low to intermediate group, then what is this group? I just kind of jumped in because there were two names to pick from. I didn't know, Anyway,
This is active surveillance. So all of these guys, nobody is seeking treatment at all. We're all the same boat as you. Most of us don't have as high a PSA as what you've got there. I thought Michael might talk a bit about a second opinion. I think he's a big fan of second opinions. We're all big fans of second opinions on pathology. You described a number of things that you kind of, are. The cipher is not a second opinion on the pathology itself. And what your doc is hanging his hat on a lot here is looking at your 3+4 sevens and saying that's his concern. So a second opinion there, and we've got examples of guys, plenty of examples of guys that have gotten second opinions and they've downgraded their pathology. So, we've got a number of different guys that we recommend. Hopkins is one. Jonathan Epstein is another, and Ming Zhao is another. But the guys are going to, most of the guys here are going to recommend a second opinion on something like that. The other is Cooperberg is a good doctor. He's very, he's a big supporter of active surveillance. But he's continuing to see you, right, Max?
Yeah, he did. I mean, it took me a while to get to see him again because they were having me talk to interns over the years, which was fine. But after the second biopsy, I kind of needed someone to scare me again. And he's been the scariest, the most straightforward about like why he really feels I need to get treatment. So I just kind of wanted to hear it from him again. But yes, so the short answer is yes. I was very happy to talk to him for 25 minutes, something like that yesterday. And I'm not happy about what he told me, but I understand he's speaking the truth, that he, highly recommends I don't wait that much longer before getting treatment.
Okay.
But I'm not sure I'm convinced yet. That's why I want to talk to guys that have made the decision to stay on active surveillance.
Yeah, which I think you might have more guys that could help you out in that regard in the low to intermediate. We are guys that are going to be sitting there saying, yeah, stay on active surveillance as long as you can. I think that, like I said, the high PSA, to be honest with you, 2 3+4s. There's other. I have a 3+4. I've got one core of a 3+4. It's low. It's a low amount. We've got guys in this group that have 3+4s, so it's not like years ago when you got a 3+4 and they march you right out to treatment. The 3+3s, Gleason 6s. You sound like you've been doing a lot of research yourself. We've got plenty of guys, maybe even Cooperberg, who sits there and says, 3+3, Gleason 6 doesn't metastasize. And, we've got high volume. We've got a guy in our group that has had a positive core in basically in 12 cores, every section of his prostate. And it's high volume. It's all Gleason 6. And he's talked with a lot of active surveillance experts that just sit there and say, it doesn't matter. High volume, low volume, 3+3, Gleason 6 doesn't metastasize. You sound like you've been active in your surveillance. How often do you get a PSA?
It's mostly been every quarter, so like 4 of them a year.
Right. In MRI, you've had MRIs every year?
Not exactly. Sometimes 18 months out, but I think, all told, probably at least 4 MRIs since, early 2019, maybe 5 plus the PSMA.
And what's the PIRAD scores on your MRIs?
That's a good question. I did grab my folder because you guys asked some good questions. I will just step back real quick and say I see the results from my 2019, and it said, let me just read this here. Oh yeah, they took 17 samples and 8 of them, which I calculated at 47% showed, androcarcinoma or whatever. And 6 of those were Gleason 3+4, and 2 of those were 3+3. And so that was the 2019 one. And it didn't get better in 2024. It didn't get much worse, but
Okay.
the majority of the samples, I guess, and both of them, of course, were MRI guided, so they knew where the lesions were. So
Right.
it looks like the majority of my biopsy samples were 3+4.
Okay.
And I don't really have the PIRADs in front of me, but I think you guys might find this interesting that, I found it interesting what Dr. Kuperberg said that, now since in the 6 years since they did my first biopsy, that they take a closer look at the 4s, I guess, to see if there's different grades of 4s. And he talked about cribiform or something. And he said that mine does not have the large cribiphores, which I think was the scariest. But he said I also didn't, he called mine like intermediate or something like that.
But he used the term cribiform and said you do have cribiform?
Yeah, but not the scariest cribiform. In fact, I
Okay.
can. Yeah.
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 Boy, Max, I would get a second opinion on that biopsy lickety split.
Okay. I'm not against that. I'm trying to get all the data that I can. Yeah. So if you guys can direct me to how you recommend I go about that, I'm happy to do that.
Okay. Well, is any of the guys here, let's see. Okay, I'm going to get you some stuff here. So I've got Ming Zhao's email, and I've got Ed Stein's, and even you can get second opinions on your MRIs if you're interested in that too.
Okay.
Here, I think, okay, I'm going to drop some things into the chat for you.
Thanks, you. Anybody else have any thoughts on Max's situation? Must strike a chord with a few of you.
Well, I just wanted to add, Max, the low and intermediate group meets on the 2nd and 4th Mondays of the month.
Okay.
Okay, that's the 2nd and 4th Mondays, and they meet. Rick, correct me if I'm wrong. In the same room, in this room, correct?
Yep.
But not yet. This room that we're in right now.
Yeah. And is Max signed up?
I've got his email.
We got his email. He signed up now.
Okay, so if the next meeting is not until the 24th, they just had a meeting on Monday.
Okay. Monday the 24th, I could try to join the load intermediate. And is that also focused on active surveillance or just more broadly people that are not dedicated to active surveillance?
No, it discusses treatment. It doesn't. There are people who have been on active surveillance, the focus of that meeting is that you've moved on from active surveillance, or you're seriously considering treatment, and you feel you might need it, and you want to talk about treatment options. Michael from Tennessee, do you want to maybe talk a little bit about the difference between that meeting and this meeting? You're currently in that mode, so you'd be a good person to talk about it. I'm just looking if there's anyone else I can pick on, but I think you're probably the best one.
Yeah, I spoke up a little bit earlier, right before you joined, and Max, I do think you probably jump over in that group as fast as you can. I think you get a lot of good guidance, and I definitely want to echo what you said and grab those links in the chat for second opinions. It made a huge difference for me. So I would
Thanks
definitely follow
again.
it.
Yeah, thank you. And thank you to all you guys. I am taking pictures. I don't know how to copy exactly from, I guess I could click on the links for the second opinion links, but I'm,
Here,
yeah, I
we're going to
appreciate.
tell you what you can do is you got the chat. You see those three little buttons by the chat line?
Uh-huh.
Okay, if you click on that, it'll say download chat messages.
Okay.
Okay, if you click on the download chat messages, it'll go to your download folder.
Super.
And
Thank you.
you
Yep.
got them all right there. That's where I stole them all. Everything that I put in today, I stole out of our one from last week. So I can tell you it works.
Okay. Well, thanks. Yeah, I will also, I will probably, thanks to you guys, try to get a second opinion on the most recent biopsy, and also check out the group on the 24th. And yeah, I'm both still dedicated to active surveillance, and I just wanted that wake up call to kind of I'll take another good look at what the current treatments are. Dr. Cooperberg did say something like, even though I wasn't ideal for focal, I guess, because I have it on both sides, he said I could do HIFU, even though I wasn't the perfect candidate for it. So that's like, those are the three things I guess I'll consider. But my gut tells me still that, I could still do some more active surveillance. But just,
come back
Yeah,
here. You don't have to leave us. We're gonna encourage active surveillance. In your case, we're encouraging very active surveillance.
okay.
absolutely. But would love to have you come back. We're going to move along a little bit, but does anybody
Oh, we've
have
got a hand
Joe?
up. Yep, we got a hand up before Bill.
Yeah, Joe's got a hand up, and Bill, I guess. Two hands.
We'll go ahead. Bill in Virginia. Oh,
How about
okay.
Joe and Victoria?
Oh, hi. I didn't realize my hand was up, but
Well, it was up previously, but that's okay.
oh, okay, yeah. I was playing around with that button, so, but I could say that I'm also one of the 3+4s, and I do attend both. I'm trying to make a decision on whether to stay on. I mean, I'm staying on active surveillance but I use the other group, the intermediate group, to talk about treatments, because I always like to have a plan B in case I get some adverse test, and that'll sway me towards getting treated. So I think it is valuable to go on both, to be on and to get information from both groups. You're on active surveillance now, so you can stay in this group, and the other one is the Monday group is also valuable, and also that cribiform was interesting too, because I'm just wondering, in general, is it always reported if they see it, or pathologists? I mean,
The problem
is that the standard pathology report? If they, because I don't have it mentioned either way on my reports, except for one.
the reason we often tell people to get a second opinion, Joe, is because it's a more recent concept, and it all depends who's reading it. That's why we're saying if you send it to somebody like a Zhao or an Epstein or the guy who came up with the crib reform scale, I forget his name now.
The one in the
They're,
Cleveland
they're
clinic.
going to identify it. And we want to be sure it gets identified because it can change your risk category now, whether it's small
Yeah.
crib reform, large crib reform, I don't know. I mean, there's a really good presentation, half-hour presentation. I'll put it in the chat box, and anybody who wants to know more about crib reform, it's a really valuable use of your time to watch through this half hour. But that's one of the main reasons we tell people to get a second opinion, because we don't know to what extent the eye of the pathologist understands and has identified crib reform.
Yeah, because one thing I know there's some new thinking from the guy, I forgot his name, from the Cleveland Institute or Cleveland something.
Yeah, that's the guy.
Yeah, who did the cribiform research, and he said that his cutoff was 1/4 millimeter, which, but I don't have in any of my reports a measure of my cribiform, but that was the cutoff. It's bigger than 1/4, then you have to be concerned. If not, he wasn't concerned. But I'm sure it's a continuum of all your stuff, but that was his cutoff. But even Epstein, I got the second opinion from Epstein. He never measured any of the cribiform. I don't have any. That's not a part of the standard pathology report.
If he didn't mention it, then you're good. Then...
No, he said no large cribiform, but he didn't say what large was. And this guy's, he didn't say if there was no cribiform. He didn't say no large cribiform, but didn't say there was cribiform. I'm just saying it's not standard reporting in the pathology, even for like Epstein to really, and that's become a real focus of a lot of thinking now, that's a key driver for metastasis.
Well, hopefully, if they see it, they say something. Don't they say, see something, say something, some shit like that? Yeah, hopefully if they see that when they're doing their report, hopefully they write it down. I would hope so.
Well, yeah, I'm just wondering if anybody knew what the standard of, because I have other, Epstein did mention it, but there was other ones that never said yay or nay on the cribiform. They just don't say anything. So I'm assuming I didn't have any.
Maybe one of these days they'll actually grade it like from A to A,
Yeah.
B, C, D, or whatever.
Well, they have done. I mean, that's why I'm suggesting you all watch. It's easy to understand because it was given to a patient group, to a group that included a lot of patients. It was in that UCSF book club, and it's introduced by Cooperberg, Max. This
yeah. So he was there. He was the moderator.
He does the introduction, and this guy Jesse McKinney has come up with about 25 different types of crib reform. But the issue is, how do you get it adopted, and how do we make it standard? So, since we can't rely on everybody seeing it, we send you to people who we know will definitely see it, and they'll tell you how serious it is in their report, and then you can decide how to respond to it.
But I think my point is that I think it's it was always considered a negative pathology to have cribiform. Now it's become very focused. And I don't think the reports now are detailed enough. Like I said,
that's what I just said, Joe. With respect, that's what I just said.
Okay.
It's not standardized yet. I think we should keep going here.
Okay. I'm just
okay. All right, Max. We certainly want to see you come back and talk to us. Let us know what you think. And I think, according to Michael in Tennessee and Joe, bounce back and forth. I think all of us. Most probably think about a plan B at one point or another. If you don't, I think you're only lying to yourself, because I know I think about a plan B, because I certainly want to stay on active surveillance forever. But if something should occur, I have an MRI next month, actually. No, next week. And there's something different. I might perhaps have to think about a plan B. So please come back and let us know what's going on.
Yeah, thank you for the time and all your input. And yeah, I'll be taking some action based on this. Thank you.
Well, thanks for sharing. We appreciate it. All right, Scott, you said you had Scott Colcord, you want a little bit of time? You're muted, Scott. We can't hear you. Scott, we can't hear you. There you go.
Okay, let's try that without shouting. I've been on active surveillance for 9 years, and my last biopsy was in 23. I get my health care the same place Max does, at the VASF and also at UCSF. Dr. Samuel Washington conducted my biopsy in 23, and it looked the same as in 2016, which was Gleason 3 plus 3, 2 cores, 5%. And at that time, Washington told me that I was now in the very low risk group.
That's
And
evident. What else is going on, Scott?
a lot of BPH. I went to UCSF for prostate surgery for BPH, and I had the surgery called HOLIP, and it removed half the material of my prostate. I had a 60-gram prostate. It removed 30 grams. Now, the pathologist said there was no cancer in the material that was removed. And Washington told me that after the surgery, I should stop taking tamsulosin and continue taking finasteride. And he said that he hoped that I would take finasteride for the rest of my life. So just 2 weeks ago, I had an MRI. The MRI said that there was no cancer found in my prostate, and also that in the central region of the prostate, they could see BPH. So that doesn't make any sense to me, that my Gleason 6 prostate cancer, 2 lesions had disappeared because they weren't found in pathology, and then I still have BPH, and here I had that HOLIP procedure. And another thing and then they say that I have a prostate of 20 grams. Now, when I was talking to the urologist on my exit interview from the UCSF for my HOLIP surgery, she said that if I had a 60-gram prostate and they removed 30 grams of tissue, that they would predict that my prostate would be a size 20 grams. And that's the way it's been turned out. But I recently had a PSA test, and my PSA is 0.5. And I found out that there was a previous request from before the HOLIP. And so I waited 2 weeks, and I had a second PSA test, and it measured the same thing, 0.5. So I'd like to get some education on what I can expect for my active surveillance in the future. Even though I'm in the very low risk group, I have some very strong family history with prostate cancer. When my father was my age, 75 this year, he had metastasized prostate cancer. And it would seem that the Orlando VA was not screening him for prostate cancer. And he had a lot of treatments, and the treatments worked. He had another 10 years. After 10 years, the prostate cancer returned, and he had, he died of prostate cancer then when he was 86. But those last 10 years would have been a lot more robust if he'd had just the RP and not all those additional treatments. So I'm quite motivated to continue on active surveillance, and I really don't have a lot of confidence in someone just looking at a chart and telling me how to gauge my PSA readings in the future. I want to be able to arm myself with some education. What do I do with a 20-gram PSA, 20-gram prostate, a 0.5 PSA readings, and my history of having Gleason 6 cancer, which has mysteriously disappeared?
Well,
In my
Scott, you're not the first guy that had Gleason 6 and it went away. Okay, you're not
Oh,
the
really?
first person. No, absolutely not. There's one on the
Oh,
screen, so absolutely not. And
okay.
looking at what you're telling us at 75 years of age, with your PSA, and now your gland is only 20 grams, and you've been seen at UCSF, which is a center of excellence, where they got good docs. It seems that you have a lot of anxiety about what? Everything seems to be good. Your cancer is gone. I mean, I'm not being a smartass, but I don't understand your anxiety over.
Well, his
I
cancer,
think,
he
yeah, I
hasn't had
think,
I don't think he's had a biopsy that said that they didn't find any cancer.
Yeah.
He's just saying the MRI, whatever they
yeah,
showed on the MRI prior.
but when
Yeah,
they took out half
exactly.
his, when they
I don't
took
have a
out
lot
half
of
his, when they took
I
out
don't
half,
think
when they took out half the tissue, they biopsied that. Isn't that what they did, Scott?
In the year 23, I had a biopsy, and it showed that I had two lesions, two cores, with 10%, 3+3.
Okay. And then you
Yeah,
had this whole lip thing
now the
done.
MRI, but let's be clear. You had an
yeah,
MRI, and the MRI isn't showing those lesions anymore, is what
right.
you're saying. But you haven't had a biopsy since you had the whole lip, right?
Correct.
Okay.
Can I pop in?
Yes.
Hey,
Yeah.
Phil.
Okay.
Sure.
So you was the first was the last biopsy, was that you've been on active surveillance for 9 years, right?
Right.
Okay, so how many biopsies? When was the initial diagnosis made? 9 years ago, and that was
Yeah,
what?
2016, February
2016. That was
2016.
two cores, two cores with minimal involvement.
Yes.
Okay, so now you had the whole lip, and presumably they looked at the tissue and they could find nothing there. In terms of the MRI, you know, uh, all the MRI does is spot areas of suspicion, and if your previous diagnosis was with minimal involvement, the chances of the MRI saying, "Hey, here's an area of suspicion," I'm not really I'm not a pathologist, but I'm not really sure that that's unusual. I've been on active surveillance 2007, 18 years. My first biopsy was exactly like yours. I had two cores with minimal involvement. I've had four biopsies after my initial one, all came back negative. I've had one MRI that didn't show anything. I've had two micro ultrasounds with Dr. Klotz, perfect. PIRADS 2, which is great. I still think I have prostate cancer. They found, you know, perhaps when I was first diagnosed, I should have had a second reading. I think in 2007, when they did that, I'm not sure second opinions were the the art of the science. I just accepted the fact that I had prostate cancer. Since then, I'd probably, my feeling would be like, you're doing well, just continue on active surveillance. Do it. Okay. I mean, I only have one question. Why does he want you to continue with finasteride?
Well, because in his opinion, the prostate is going to continue growing, and he wants me to continue finasteride for reasons of BPH. But the thing is that Washington specializes in cancer, and all the urologists at UCSF that specialize in BPH say to stop taking finasteride.
Yeah,
But then,
I'll tell you I was on dutasteride, which is like finasteride, for I don't know 7 or 8 years, and then I came across something that Klotz had said in terms of and his opinion was that if you were long-term active surveillance, it wasn't really doing anything for me. My PSA, so my PSA had always been in a fairly narrow range, and it's still in a fairly narrow range. Only it's doubled from what it was when I went off the dutasteride. But I mean, I'm still continuing with active surveillance. I'm seeing twice a year, and hopefully it'll continue forever. I mean, that's what I'd like to do.
yeah, okay. Yeah, I know that finasteride really complicates the PSA levels.
Yeah, well, it'll cut it in half, and it also,
Yeah,
and it also doesn't do a whole lot for sexual function. So,
yeah,
I mean, depending upon, I mean, I guess everybody's got their own idea of what they'd like to be at I guess our age, and you know, I thought I'd be a lot better off without it than with it, but I mean, that's me. I'm not suggesting that anybody, follow what I do. I I looked at my risk. I looked at what Klotz had said, and I'm happy to be off it.
Well, Scott,
yeah,
if you got off it, if your PSA is 0.5 and you double that, that would be 1,
Big
correct?
deal.
That would be a 1. So
yes, right,
I
right.
don't think you're jeopardizing your health.
Yeah.
And I'm sure a couple of your doctors that you're seeing will agree if you stop taking, I think that's a personal decision and you don't have to make a lifelong commitment. You can stop taking it, see how the BPH reacts, see how your sexual function reacts, see how your PSA reacts. Um, is there anything else? We got some other people that I need to get to. Is there anything else we can help you with? Because you seem to be well researched and you're seeing good people and things seem to be under control.
Yeah. I was wondering what I should look at in the future for my PSA levels. What PSA levels should I be concerned about going into additional diagnostics or even fear or treatment?
No, just low. Low is the key. What you're looking for is low. LOW, low. Just get it checked every 6 months, maybe. Um, don't do anything differently than you're doing. There's no other than a PSA test whenever you feel is proper, whether it be every 4 months or every 6 months or what your doctor recommends. Um, an MRI. I don't know. Your last MRI was what, two
2 weeks ago. I mean,
2 weeks
if
ago?
my PSA goes to 1, that's a doubling.
Oh
Yeah,
yeah, no,
but
but that's
But the
because
number is 1,
Scott,
Scott.
it's
The
not a
number is
question of
1.
a doubling. It's not a question of a doubling. It's a question of where your PSA is and your history. You can make yourself nuts. You'll be jumping off the bridge before we know it. You don't have anything to worry about, man.
yeah,
Here's the issue. Your dad got sick and he had metastatic cancer at 75 and it wasn't treated right. You are right at the other end of the scale. We found it. You've been watched. You've been treated. We just took 60 grams out of your prostate. That's why you've only got 20 grams left. Why don't you have it? It probably went with the 60 grams that they took out of it. So, there's all these things going on. I don't think we should be looking for reasons to worry ourselves. We should be looking for reasons not to worry ourselves.
yeah,
And you
agreed.
should be
Okay.
doing a complete 180-degree. I shouldn't say you should, because you do what you have to do. So forgive me for that. But I would be looking at all the good things that are happening, and there's so many good things that it's overpowering.
There's no
And
bad things.
and rather than being an Eeyore about it, let's look at what's positive. 20 a 20-gram prostate
Wow.
would which is what you have now, would normally, for a man in his 40s or 50s, would produce a PSA of around 2 if they produced a normal amount of PSA. Now, you're older than that, so it should be a little higher. But you've had the BPH surgery. I mean, my feeling is, 2 grams, and if your PSA is 2 or somewhere around 2, adjusted for the finasteride, you're doing great. And you've got somebody who's watching you. I mean, there's a lot of people, and you can read Howard Walensky on this, that think you don't even need to keep worrying after the age of 75. Howard's written about this times.
Yeah.
I put one link in the window for you. So, there are a lot of people that might say we don't need to see you again.
No, Scott, I think everything's you've got everything's in order. You're looking for problems that don't exist. At least that's my opinion. I'm not a doctor, but I mean, you're worrying yourself to death when you really shouldn't. I don't know what you should get another hobby. Get another hobby. Collect coins, collect stamps,
Okay.
watch Netflix,
Okay.
do something else. Do something else.
Okay.
You're in good.
That sounds
Just do
good.
what you're doing. Do what you're doing, and not worry so much, because I got news for you. Most probably 50% of these guys you're looking at would like to be in your. I would like to have
Hell
a 20
yes.
gram
Oh, yeah.
prostate.
Yeah. I
Trust me.
realize
I
that.
would
I've,
like
I've
to
got
have a
some
1
good
point
numbers.
PSA.
Yeah. Yeah. Okay. Well,
Deep
I
relax, brother.
appreciate
Take
your
a couple
input.
of breaths.
Yeah.
All right.
Okay.
Now we're gonna leave you alone. You think about that. But we're gonna leave you
Okay.
alone now, unless somebody's got something real quick. Derek, you got something for Scott?
I was just going to say, I think the current reference is 4.0 on PSA when they start to raise their eyebrows. So you're well under that.
Yeah, that's what that is basically. I hear 4 and I hear 2. It depends upon what you read, but and I guess depending upon age and family history. But Scott, you take a couple of deep breaths and you listen to some of these other guys.
Yeah.
All right,
Okay.
Dave, what do you got?
I just want to let you know, last week you recommended a second opinion, and I had requested my slides be sent to Dr. Epstein. So I just want to let you know I followed up on that.
Excellent. We love to hear that. I know you were new last week, and I'm glad you did that. And certainly come back next week and keep us informed on what he says. Would be curious. I think he's charging $400. I don't know if Medicare takes care of that or not,
Yeah.
but
It's worth it, whatever it is. So,
I feel the same way, my friend. Absolutely. And also, if there's something of concern, you can get in touch with him, and he will talk to you. He will make an effort to converse. So that's really good.
all
But
right.
that's great getting a second opinion. And as we said, I'm sure you learned last week, we are big proponents. So that's excellent. Anything else, Dave?
That was
Gary,
all.
Dave, just curious, Dave, what was the process that you did to get the second opinion?
Well, I put the website in the chat that's Dr. Epstein's website or his clinic. And there was a way to print a form on there to request it. So I printed the form out, then I went to the doctor and he filled out his part, and then I took it to the lab and they said they'd send it in. So
Good.
I did
Yeah,
that.
sometimes hand carrying things gets it done a lot quicker, although the docs most likely could have taken care of that for you. Your doctor passing it to the lab, but you're doing it the way you did. Most likely will get the fastest results, and after he looks at them, he'll FedExes them back to you. So
Okay.
you might even have them next week. We'll see.
All right.
Okay. Well, thanks for sharing, Dave. Thanks for coming back. Glad to have you here. Michael, we've spoken from Tennessee. We've spoken to you a few times this evening. Do you have tell us your good news?
Yeah, I think it's good news. It is good news. I did the second opinion with Epstein. That was a pretty drawn out process on my end. So Dave, I think walking around like you did was probably probably a wise move, because it took me forever to get my doctors to do anything about it. To the point to where when the results came back, the lab wouldn't even give them to me. which was odd. But they did tell me that it had gone from, originally I had 2 positive cores, one 3+3 and one 3+4. And all the lab told me when I went in there was, we can tell you it's gotten worse. You've got 6 or 5 positive cores now out of 17, which is why I kind of bowed out of this group and said bye last time. I don't know if anybody remembers that, but I was like, okay, I guess I'm going to the low to intermediate group. But when the doctor finally did give me Epstein's report, it was all 3+3 across the board.
Oh, oh,
Excellent.
nice.
Excellent. Way to go.
Nice.
Congrats.
I didn't do anything, but thank you.
Yeah.
I just followed y'all's advice. So I deeply, deeply appreciate what all you guys did, recommending me get that second opinion, and definitely want to echo that out to the guys in here that are considering that. It made a big difference in my case. And meeting with Eric was amazing because he had a lot more positive. I really was still considering possible treatment even after that, but he mentioned that, I think the way he put it was, I wish I had your numbers, right? So,
Hey, we wish we had Scott's numbers. The hell with Eric's numbers. I want Scott's numbers. He's worried about, he's going to be going to bed all nervous and jerky. I wish I had his numbers. Shit. All right.
That's true.
Well, Mike,
That's
again,
the update on my end.
I'm glad that that's working. And of course, you know, you're going to be as active as you can be. I'm sure you have in the past, and you will be in the future, especially with, I don't want to say a scare, but you know, yeah, I would consider it a scare if I was in your shoes, that, you know, that has come my way. So I'd stay, you know, I know you're going to stay on top of it. And again, we are unbelievable proponents of second and third opinions. And this is a great story. This story, these are the kind of stories we love to hear. So thanks for sharing. And I'm glad that got better for sure. Mike M., you wanted to make a comment?
Yes, just yeah, I was fumbling with the virtual button. I was just curious, and it's very minor, but I'm in Minneapolis, so I have 2 resources if I do decide to move forward. So I'm jumping the gun a bit, but I'm not hearing anything on the University of Minnesota. They have a Masonic Cancer Center. So you know, they'll be like 20 minutes away from me, you know, 30 minutes at the most. But then there's Mayo down in Rochester, which is a little bit under 2 hours. So I'm just curious, has anyone heard anything about the Masonic Cancer Center? Have an opinion, or maybe you can point me to somewhere where I could get to know a little bit more about them?
Rick would be our most informed person about centers of excellence and locations. I've never heard of the Masonic Cancer Center, but I certainly heard of the Mayo in Rochester. So
yes,
I go 3.5 hours to the Mayo Clinic in Jacksonville, Florida.
So Masonic is the University of Minnesota.
Yes.
Isn't that right? Because there, and there's another one also, which I always forget the name of, but Masonic is the University of Minnesota in Minneapolis. I think it's an excellent center. It would be my choice over Mayo every day.
Oh, wow.
The former chief of I don't know if certainly of the oncologists was Chuck Ryan, who then went on to be the CEO of Prostate Cancer Foundation, and he can now be found at Memorial Sloan Kettering. He was replaced by a guy called Emmanuel Atanarakis, who's a terrific doctor. As far as I know, the urologists are all pretty good, and I think their radiation oncologists are too, although I don't know them so well. But I certainly wouldn't travel to Rochester when I could just as easily go to University of of Minnesota. It's an NCI center. I don't think it's an NCCN center, but I can't remember.
Well, that's okay. That's right there is plenty for me. I was kind of leaning there that way because I think it's pretty important if you can be local. I think it's just better from in terms of getting support, et cetera, being home. So thank you. That was my question.
All right, Mike. Well, I'm glad that Rick could answer your question. Carl.
I mean, I would say keep coming back, and if it gets to the point that you need treatment, you'll go into the next group, and when you get into that next group, we'll come up with the right names for you to talk to at Minneapolis at Masonic. I've got a few names from people who have been treated there. I'd have to look them up. But in push comes to shove, we can ask Dr. Antonarakis for his recommendations because he knows us well enough.
Okay, I think I'm going to be okay for a while. I'm a 3+4, but it's only one core, and so I think I can. Yeah, I think I'm. Yeah, the last week's meeting was very reassuring for me because I've heard other people chime in on that. So I think a lot of us maybe, and it was mentioned before, when you hear that 4, you tend to panic. And even my doctor kind of he's a little on the aggressive side, the surgeon. So I panicked a little bit, but this has been very reassuring to hear this group, especially last week. There was a little bit of discussion. So think I'm good. I'm not going to move over to the other group yet. I'll wait and see how things progress. But right now I'm feeling really good, and I appreciate hearing everyone's feedback here. It's been very helpful.
Yeah, if I see you in that group, I may have to kick you back down to this one.
I would only do it if something changed and an MRI or a biopsy or something led me to conclude that. But right now I'm feeling good to be here. Thank you.
All right, Mike. Good to hear. I'm glad Rick was on, so he could can certainly drop some names, and reassuring in your choice is a good one. Carl,
I just want to make sure we don't have anybody from that area who sought treatment, do we? We don't have anybody from that area, the Midwest, who's used any of those facilities. I don't think so.
No, I don't think so. That's the first time I've heard of it. Is tonight. Okay. I would have remembered Masonic. Carl, are you still with us? Carl might have flew to Coop. All right, I'll get back to him. Ignacio, what do you got for us, buddy?
All right, this is going to be super quick. I wanted to say that I encourage everyone, if you have not already, to watch the video that came out a couple days ago from PCRI. You can draw your own conclusions, but I took it as a message of hope.
And that was a video on what?
I can post the link in the chat.
It is great.
Okay, please do that.
Yeah, testing and monitoring prostate cancer. And what I found what I took, personally as a message of hope is that he says, and he is Dr. Scholes, he says that when they find cancer in you, right, in the prostate, since it's a slow growing cancer, it's probably been there for a while. So if it hasn't metastasized yet, the longer that you go without seeing metastasis, that's actually a good indicator that your odds are pretty good that it won't metastasize in the future. But again, that is how I interpret it. You can draw your own conclusions, and I'll post the link right now.
Well, thank you very much. And I've been active surveillance almost 15 years now. 3 + 3 = 6. So I'm hoping that pertains to my particular case and to everyone's case, that we live long, healthy lives and expire from something else other than prostate cancer. That's for sure.
Gary, I like to say the trend is your friend.
Isn't that clever? I like that. The trend is your friend. I'll have to write that down, yo. There you go.
It's the same in stocks, right? The trend is your friend.
Well,
There you go.
I'm going to hope that trend breaks pretty soon, because it's been brutal out there.
Okay. All right. Okay. Carl was new last week, and he's also a member of the veterans group. I guess maybe he had to run. Carl, you out there? I believe he has.
Gary, did you mention the veterans group to Max?
Yeah.
No. Max, are you still here?
Yeah,
Yes.
you did.
Okay. Yeah, we have a veterans group that meets every other Tuesday. And it's in a different room. Rick, can you post, is it the Schmear? Schmear, like a smear of
Yes, just like a smear of cream cheese. Yes.
Schmear. All right. Well, now I'll know how to say it. Schmear.
Yeah.
Okay.
Yeah, I'm happy to post it, but also when Hugh or whoever sends the names to be to Kenan or whoever, please ask them to put a tick by veterans for Max as well.
You bet.
Yeah, you'll take care of that. Yeah, Max, we have
Yep, I got it.
a gentleman by the name of Captain Jim Marshall who's in charge, and we've got generals, we've got colonels, we've got psychiatrists, we got all kinds of people in the veterans group, a lonely Spec 4 like myself. And are you collecting any disability from the VA?
Yes.
Okay. Well,
we can guarantee we'll get you more, right, Gary?
Yeah, that's exactly what I was going to say. Jim Marshall will find something that you can apply for. Trust me. So he knows all the forms. He will personally one-on-one, meet with you, Zoom with you, help you if he thinks there's any other financial gains to be had. So that's a whole nother story, but please join us. I'm in that one myself. I'd be happy to see you there. Okay, Max?
All right. Thanks.
All right. Michael Thompson joined us late. Michael, are you still there?
I am here. I don't need any time tonight. Thank you.
Okay. All right. Just wanted to double check.
I appreciate
Eric joined us late too.
Who's that?
Eric joined us late.
Oh, Eric from Atlanta?
Yep.
I am here.
All right, Eric, I got a quick question. It doesn't pertain to prostate cancer, but when you met with Michael, your email, are you some type of photographer, a videographer, a filmmaker, a document? What do you do?
I work on TV commercials in Atlanta.
Oh, okay. I was just curious when I saw all that stuff next to your name there. It's pretty cool. All right.
Yeah.
Do you need any time?
Yeah, I got a quick question for the group.
Go ahead, shoot.
All right. So my MRI and PSA trend have been stable, but I feel like my doctor, Dr. Sanda, wants to do a biopsy still because it's been just over a year and a half. So I'm vacillating whether I should let him poke it or not. That's my big question.
Well, have you read the latest about negative MRIs? Kind of say that you really aren't in the need of a biopsy. I think I read it. Howard put something out in the Surveiller.
I wish I was negative, but I do have lesions in there.
But there's no change, is what you're saying, right?
Not from the previous one in July. The last one I had was a week ago, and one is still a Pyrad 3, and then one is now a Pyrad 4, but the previous one said a Pyrad 5.
And
So
Eric, the unique thing with you is you're high volume.
right, but
Yeah.
only one biopsy.
Only one biopsy. Ah, okay.
Right. That's
Yeah.
sort of the zinger a little bit.
Yeah, I think here again, we're not doctors, just talking amongst, everybody in the same boat on the journey.
Right.
It's got to do with your peace of mind, I think, too, Eric. A big part of it, maybe anxiety, the fact that you say one biopsy and, that high volume thing kind of, proverbial rings the bell a little bit. I think I'd have to, if it was me thinking about myself, the way I react to my own whatever, I would most probably agree and try to get another stable, another biopsy that comes back the same way as the first one, or lesser, after I got a second opinion and stuff of a lesser. I don't know. Everybody else, come on, you guys got to have an opinion. He's painted the picture pretty plainly.
I did two back-to-back within a 24-month period. They both were Pyrad 4 with showing lesions, but the second one didn't. Actually, one of the lesions disappeared on the second one, but a new lesion had appeared. But again, still stable at Pyrad 4. So, and that was this last July.
Okay.
I think nobody likes the biopsy thing, I don't think. There is something to be said about, you don't want to poke it too many times, I guess. That's for sure.
Pop the balloon, yeah.
But again, since only one biopsy, this would almost be like a confirmatory biopsy. The second one is sometimes called, I think, a confirmatory biopsy to kind of put to put you at mind that nothing's changed from the previous one.
My PSA had changed, Eric, from the 24-month period, 12-month period. Prior to, it was at 4.2 and then jumped to 5.2. And that's what prompted the second biopsy at that point. But no change in biopsy.
How's your PSA been, Eric?
It's been stable for the past year at low 5s. And it's basically gone down from the initial one, which triggered the whole journey, which was 8.7. That was before I knew anything about exercise and all that not to do.
That most probably was a case of prostatitis, which you did not know was most probably inflammation of the gland. You had no idea, no symptoms, no signs, just like mine went from 6 to 12. You can just have that stuff from time to time, or how your body carries inflammation, but that most probably was the story of the 8.7. So, and then being stable in the low 5s. But
yeah, it's basically trending down from there.
Most everybody, has had a confirmatory biopsy, I take it. Everybody out there, more or less, that's been on this boat for a little while after the initial one.
Mine has stretched out to about 4 years, but Eric, I don't know if I were in your shoes with the high volume that I would push it. You're coming up to 18 months. My own. I think if I were in your shoes, I wouldn't push it much past 2 years.
Okay. Well, the next one will be targeted too, which the first one was not.
Yeah.
Well, and it's not like you got to do it tomorrow either. Like you said, if you want to wait 6 months, you want to wait till when you're not busy at work. You want to wait till you want to take a break. Schedule it around your needs, not basically, anything else. That might be the way to go. But most probably, targeted confirmatory biopsy will most probably, hopefully, put your mind at rest, and then you can, hang out with us.
Okay.
Did you have a transrectal or a transperineal?
The first one was rectal before I knew anything. And it was
Right.
before the MRI.
Oh, an ass
Yeah,
backwards doctor. I know those
yeah,
guys.
I fired him. Yeah.
Yeah, I did mine too.
See, the trend is your friend. They do it ass backwards, they get fired. See that? The
Yeah.
trend is your friend. There you go.
You know,
All right.
you and Eric, you should have sent them to ANCAN.
Who, the doctor?
Yeah, the doctor.
Yeah, exactly.
All right.
In hindsight.
Anybody else got have anything else for anybody?
Yeah, I want to say just a couple of things here. Mr. Tosca, you are calling out the praises of our fine advisory board member, Howard Walensky, for doing that article on MRIs and if they're negative and everything. But that's what we featured on March the 4th last week in our own reminder. I hope you opened it and I hope you read it.
Well, maybe that's where I read it. I don't know where I read it.
Well, he did it too. He did it too, because we talked about it, because I felt that was one of the most important articles I've read in a long time for men on active surveillance. And I've put the article, I don't know if you'll get it that way. I'll pull it up again and put in a second reminder. That's the reminder that goes through the, that's the link that goes through our MailChimp. But here's the link from JAMA Network. Right there. It's an awful long link, but that's the link from JAMA Network. And yeah, I think it's a very, very reassuring article for a lot of guys who are on active surveillance. And that's why we put it in, and we hope you'll look at it. It's a great article. I mean, it's not pertinent to Eric. So that was one thing I just wanted to say. I thought there was something else. Oh, I did, Eric. It sounds like you're driving. I put a message in the chat window for you, but I may try and reach out to you tomorrow if you're around.
Okay, thank you.
Okay. I think that was it. I don't know what else was on my mind, but it couldn't have been very important.
All right. All right. Well, I guess we can say good night. What do you think? Anybody else got anything?
How did you guys get on starting? Did you start the room okay? Because I got delayed, and Alexa, if any of you want to send her a note, poor Alexa got diagnosed with COVID today.
Oh.
And she's not feeling good at all, and she's got a really bad sore throat. So I know she was going to come in right at the beginning, but hopefully you got started okay. But yeah,
I had some computer problems, so I was delayed getting the room open. But that was on my side. Didn't have anything to do with ANCAN.
Okay. We can stop the recording now whilst we're being very honest about all the errors.
Very good.
This conference will now be recorded.
Okay. I won't keep very long. I just want to say again, thank you for the group, because after that, I decided to go back to my urologist, and I got the approval to go have a second opinion. So I got that in writing. I also got set up for a new MRI and a PSA. So a new evolution is starting, and so that's very good. But I have a couple questions. You guys were talking about a cipher test or a decipher test. I never heard of that before. Nobody mentioned that. What am I missing?
So decipher test is what's called it's in the realm of a genomic test. And so there's a couple of different types: decipher, Oncotype DX, and I can't think of the other one.
Polaris.
But Polaris. It's a genomic test, and what they do there is they usually take the core from your highest Gleason score core, and they send a sample of that sample to one of these guys, and they will tell you, based on statistics, whether you have a low risk chance of that cancer or a higher risk chance of that cancer metastasizing over, usually they talk about a 10-year period.
Okay, so they run a
So
statistical model, and this is something I routinely is done. I should have that done.
a lot of the guys here have had that done. A lot of times you have it done just after your first diagnosis. A lot of times guys won't have it continuing after the next confirmatory biopsy or multiple biopsies. You don't always get another genomic test, but it should be something that you could ask your doctor. I certainly had it when I was first diagnosed, and a lot of doctors use it as a way to say, okay, we're in good shape to to go on and continue with active surveillance. Certainly
Okay.
was something that helped me in that regard.
Excellent. Thank you very much. What is a pyrite score or a pi? Is it like pi, like the letter pi? The pi?
PIRADS, PIRADS, and that's the score on your MRI. So
Okay,
if it's a 1 or a 2, it says that they don't see anything of significance. If it's a 3 or a 4, they usually will use that as a marker to say, okay, we should look further into this. It's usually a PIRAD score on the lesion that they see. So if you had 2 lesions, it might give you 2 PIRAD scores on those lesions. If you've got a 4 or a 5, it definitely is going to say you should have a biopsy. If you've gotten a biopsy already, that trumps really what your MRI said. So it's not like, if you've gotten a biopsy and you've been diagnosed, it's not like you want to sit there and say, okay, well, I'm hoping for a better PIRAD score on my
that ship
MRI.
has sailed. Okay, understood.
Yeah.
So that ship has sailed. Once the biopsy is done, then the PIRAD score is something in the past.
Somewhat, yes.
Yeah.
Now the importance is the MRI. What's important with an MRI is you're building, number one, you get your first one. That's the baseline. Then, in my case, every year I get another MRI, and they're going to compare it to the previous MRI to see if there's any changes. And as long as there's not any changes, in my case, there weren't any changes from year to year. So the doc said, no, we don't need to do a biopsy.
Again, the trend is your friend.
You got it. And
Carl, I just wanted to add that a decipher score is just another part of the basket. In other words, you don't put all your eggs in one basket. We have people that have gotten, I don't want to say bad decipher scores, but let me say high decipher scores, and yet their Gleasons are low. Their PSA is where it should be, and you can't get all nervous and jerky about one particular test. My guy doesn't like genomic tests. He says his gold standard's the MRI. I have not had a genomic test. He doesn't believe in it, and at that point, I didn't know enough about it. Perhaps with my next biopsy, which will most likely be next year, I think, depending upon my MRI next week, I might opt to get, for the hell of it, I'll be 76 at that time. Maybe yes, maybe no, but don't. It's a good thing if you want to do it. But as I said, hopefully, you just there's a lot of pieces to this puzzle as you go further along, and you don't put all your eggs in one basket like if you had an outrageously high PSA for a short period of time. It could be a lot of different things. So just you kind of being a new guy, just want to let you know that, it's a big picture, and you use all these diagnostic tools and all these second opinions, seeing people, being seen at people that know what they're doing. They've been around it longer than most. Helps you make the most educated decisions that work for you. So I just wanted to add that about that Decipher score thing. Okay.
Thank you very much. Much appreciated.
And I do believe that the Decipher score, isn't that data on people that have been treated, Rick? You're muted.
Yeah. They have a huge database, which they base their model on.
Yeah, I got a problem with that myself. So, they know more than I do, but I just have a problem with them running all those numbers on people that have been treated.
Okay.
If they had one for like AS guys or non-treated cases, maybe I'd be a little bit more forthcoming with their conclusions. Well, does anybody need anything else? I'm glad we got to you, Carl. I'm glad you came back.
Okay, I got one more little thing.
Oh, go ahead.
And I worked with Jim Marshall, and he recommended that this is a little different. This is medical. He said you should seek from the VA via the PACT Act the compensation. I just wondered, in this group, which is mostly people under active surveillance, are other people on that program with the VA? The financial compensation?
Oh, I am.
You are, okay.
Yeah, I have prostate cancer from Agent Orange. Max Caruso, who joined us earlier tonight, he's a vet receiving disability. Although I didn't ask him if it from the VA what it was for. So yeah,
there are people here. Okay, there are people here who are doing the same thing. So it's not like it's an oddball.
Absolutely not. And if people, are veterans and have served in different areas, different conditions, if they're not receiving disability, they're kind of foolish. They can get health care, they can get a lot of things. And we have a group for that. Okay, is that good?
That's it. Thank you very much for waiting for me. I appreciate it very much.
Okay, you're welcome. All right, I think you want to wrap it up and we'll hang out for a minute?
Yes. Yep. Organizer, stay on.
All right.
Thanks, all. We'll see you next
have a good
week.
evening. Thanks for everything.
Thank
See
you.
everybody next Wednesday.
Thank you, gents.